Hey guys, welcome back to my channel, The ENT Resident. Today we'll be discussing a very important topic, both from your practical as well as theory perspective. And today's discussion is going to be about the differential diagnosis of a membrane over tonsil. Very commonly, you get your tonsillitis case as a long case, and invariably, the examiner asks you this question. Can you give me the differential diagnosis of the membrane of tonsil? And it can be very hard for us to remember, okay, what were the different causes? So today I'll be discussing each one of these causes, and I'll also help you by giving you a mnemonic to remember the 10 different causes. And we'll also discuss what is a true membrane and what is a pseudo membrane. You can also purchase my notes. Now I have added links in the description. Okay, so let's get started. So, what is a membrane over tonsil? Now, a membrane over tonsil is basically referring to the presence of a whitish or a grayish or a yellowish coating, which can be a true membrane or a pseudo membrane over the tonsillar surface, and this can happen because of infection, necrosis, or infiltrative disease. So, that is what a membrane over tonsil is. Now, how do we know whether it is a true membrane or a pseudo membrane? How do we find that out? So, pathologically, if we look at it, true membrane is actually composed of fibrin and necrotic epithelium. And the important part over here is that it is firmly integrated with the underlying tissue. That means it is very firmly adherent to the underlying tissue. Whereas for a pseudomembrane, this is more of a superficial exudate that has formed over the tissue. Now, this superficial exudate can contain fibrin, pus, debris, microorganisms, etc. And a very key point is that this is loosely attached. So, this is a very important difference to remember between both of them. The composition is different as well as the adherence. Now, when you try to remove a true membrane, you will see that the tissue starts bleeding and it leaves behind a raw surface. Whereas in case of a pseudomembrane, it will not bleed when you try to remove it. Sometimes you may see an ulcer or mild erythema over the region after removing, but it will not bleed. So essentially, what we are seeing is that true membrane is usually involving a much more deeper tissue involvement and a toxin mediated necrosis, whereas pseudomembrane is more of a superficial process that occurs. So, if we had to ask you a typical example of a true membrane, we will be talking about diphtheria. So, in diphtheria, the diphtheritic patch that you see over the tonsil, that is actually a true membrane. And if you try to remove it, it's going to be very firmly adherent to the underlying tissue and it will bleed and leaving behind a raw surface. Whereas an example of a pseudomembrane would be a case of acute membranous tonsillitis. So when you try, if it's a case of acute membranous tonsillitis and you try to remove this white membrane that you're seeing over the tonsil, it will not lead to any kind of bleeding. If you want to know more about the different types of acute tonsillitis, you can check out my video on that. So that's about a true membrane as well as a pseudomembrane. Now let's talk about how are we going to classify this differential diagnosis of the membrane over tonsil. So everything needs to be set in a very systematic manner. So don't just go about mentioning random names of diseases in a very haphazard manner when you're asked the question. Rather, if you want to impress your examiners and get good marks, you start with a classification. So we'll classify this into infectious causes and non-infectious causes. Amongst infectious causes, we have bacterial, viral, and fungal causes. So amongst the bacterial causes, we have acute membranous tonsillitis. We have diphtheria, where we see the true membrane. Then we have Vincent's angina. Amongst viral causes, we have infectious mononucleosis, and among the fungal causes, we have candidal infection. So these are all the infectious causes of formation of a membrane over tonsil. Now coming to non-infectious causes, this can again be further classified into ulcers and malignancy. And amongst ulcers, we have traumatic ulcer and aphthous ulcer. And amongst malignancy, we have malignancy of the tonsil, leukemia, and agranulocytosis. So these are our 10 causes that we are going to discuss today on the differential diagnosis of membrane over tonsil. Now, before I dive into the 10 different causes and what are the key features in each one of them, I want to give you a mnemonic that will be easy for you to remember the 10 causes. So, first of all, let's look at our first. The mnemonic is, the mnemonic is damp, TV, calm. Now, for D, we have diphtheria. For A, we have agranulocytosis. For M, we have mononucleosis, which is for infectious mononucleosis. For N, remember it as neoplasm, which means the malignancy of tonsil. For T, we have tonsillitis, and more specifically, the acute membranous tonsillitis. For V, we have Vincent angina. For C, we have candidal infection, A for Aphthous ulcer, L for leukemia, and lastly, another M where we will remember mechanical, meaning traumatic ulcer, which is a mechanical ulcer. So these are our 10 different causes here that you can easily remember with the help of this mnemonic DAM, TV, CALM. So now let's get started with discussing each one of these causes. So first of all, we'll discuss about acute membranous tonsillitis. Now this is one of the most common causes that you will be coming across. So in acute membranous tonsillitis is essentially the next stage of a case of acute follicular tonsillitis. Now what happens in acute follicular tonsillitis? So there's an infection going within the tonsillar parenchyma and the lymphoid follicles are involved. Now what happens is there is formation of exudate inside the crypts. Now, first, in acute follicular tonsillitis, what happens is these exudate starts coming out of the crypts and they present as these yellowish white spots on the surface of the tonsil. Now, this stage, if it continues going on, what happens is all these exudate that are coming out as these yellowish white spots, they start coalescing together and they end up forming a membrane over tonsil like you're seeing in the image over here. So this is formed a yellowish whitish membrane over the tonsil. So acute membranous tonsillitis is basically the next stage of acute follicular tonsillitis. Now the common cause involved over here are mostly due to pyogenic organisms, but the most common cause to remember here is the group A beta hemolytic streptococcus. And the feature of this membrane that we are seeing over here, this is actually a exudative membrane. And when this membrane has formed over the medial surface of the tonsil, and this can be easily removed and it will not bleed when you remove. Other than this, the patient will come to you with all the features of acute tonsillitis like sore throat, fever, dysphagia, etc. So that is our first differential diagnosis here, and this is acute membranous tonsillitis and probably one of the most common causes amongst all of these differential diagnoses. Next, let's talk about diphtheria. Now, diphtheria, the cause over here, as we all know, is a case of Corynebacterium diphtheriae, which is a bacillus, which is a bacterium. So in case of diphtheria, what you will be seeing here is the patient will have a much slower onset as well as less local discomfort. And when you examine their oral cavity and the oropharynx, you'll see a thick membrane has formed over the tonsil, and it can sometimes even extend beyond the tonsil to go on to involve the soft palate as well. This will be dirty gray in color. Now, a very key difference of this from all the other differential diagnoses here is that this membrane is going to be a true membrane, meaning it's going to be firmly adherent, and when you try to remove this membrane, it will leave behind a bleeding raw surface. So the only classic example here that we are going to remember as a true membrane is that of diphtheria. Now, in this case, the other features that you will be seeing is the patient can have a bull neck appearance, which occurs because of cervical lymph node enlargement. When you do a throat swab and culture, you will find that there are Corynebacterium diphtheriae in it. And a urine test may show you albumin as well. So that's about diphtheria. Next, we move on to our third cause where we will be discussing about Vincent's angina. Now, what is Vincent's angina? Now, Vincent's angina is this acute necrotizing infection of the pharynx. What is the cause behind it? The two different bacteria involved, the two bacteria involved here are the Fusiform bacilli, and then we also see the involvement of spirochetes. And among spirochetes, the organism very commonly involved with this is known as Borrelia vincenti. So that is the cause for Vincent's angina, which is a case of acute necrotizing infection of the pharynx. Now, in these cases, where mostly they'll have a very insidious onset, the occurrence of fever is much less. There is less discomfort in the throat. The patient will have a foul breath. And the membrane, usually, another important feature here is it will form over unilateral tonsil, that is over one tonsil only. And this again is a pseudo membrane. It can be easily removed away, but on removing it, you'll reveal an irregular ulcer over the tonsil. And when you do a throat swab, it will expose fusiform bacilli and spirochetes. So that's about Vincent's angina, which is a third differential diagnosis. Moving on to the next one, we have our infectious mononucleosis. Now, infectious mononucleosis is something that is very commonly known as glandular fever as well. Can you tell me what is the cause over here? Infectious mononucleosis is caused by Epstein-Barr virus mainly, and this disease most commonly affects young adults. Here, what you will be seeing is both of the tonsils, they're going to be enlarged, they're going to be congested and covered with a membrane, and there will be a lot of local discomfort. And a very, very important feature here is that you will see that lymph nodes are enlarged in the posterior triangle of the neck. Along with this, you'll see more systemic manifestations like presentations of splenomegaly. And very, very, very important point is that there will be a failure of antibiotic treatment. So these points should point you towards the diagnosis of infectious mononucleosis. When you do a blood smear in these cases, what you will be finding is there is more than 50% lymphocytes. And of these lymphocytes, about 10% of them are going to be atypical. So, what we see here is a case of atypical lymphocytosis. And when you look at the WBC count, the WBC count is going to be normal in the first week, but it will rise in the second week. And the most common test here that we do is the Paul Bunnell test. This will show high titers of heterophil antibody. So this is about infectious mononucleosis, which is also known as glandular fever. And here, some of the important features to remember are that we have a failure of antibiotic treatment, we have systemic manifestations like splenomegaly, posterior triangle lymph node enlargement, we have atypical lymphocytosis, and Paul Bunnell's test. So that's about infectious mononucleosis. Moving on to our next cause, we have candidiasis. If we look at the image on the right side over here, this is what a typical image of oral candidiasis looks like. And the cause over here is Candida albicans. And what we see here is there will be white curdy patches or plaques all over the mouth. And when you try to remove these patches, they'll leave a red raw surface on removal, but there will be no bleeding. And this very important feature here is that this will be seen in immunocompromised patients mainly. This is a very important differentiating factor over here. So we have gone through 5 causes so far, and these have been the acute membranous tonsillitis, diphtheria, Vincent angina, infectious mononucleosis, and candidiasis. Moving on to our next cause, we have the traumatic ulcer. Now, a traumatic ulcer is, as you can see from here, it's something of coming that is coming from a mechanical trauma. So, any injury to the oropharynx can heal with the formation of a membrane over the region. So the trauma to the tonsil area, that can happen accidentally when you hit it with a toothbrush, or maybe you're using a pencil. Sometimes we end up just putting the pencil in our mouth by mistake, and that can end up hitting the tonsil, or a tooth bite, or a fish bone, or very hot food. Any of these things can end up causing a traumatic ulcer. So, very key point over here would be that there will be a history of trauma present in these patients, and that will help you in coming to this diagnosis. And this slough that forms over the tonsil, in this case, it will come off and it can reveal a raw ulcer base. And very important to remember here is that post the trauma, the membrane usually appears within 24 hours. So, this is about traumatic ulcer. That brings us to our next one, which is another ulcer. This is known as Aphthous ulcer. Now, Aphthous ulcer is something that we have all experienced at some point in our life. And as you can see in the image, this is what an Aphthous ulcer looks like. Typically, it has a round or an oval ulcer, and this can be very recurrent, and it can involve any part of the oral cavity or the oropharynx. Sometimes you can see a single ulcer, sometimes you can see multiple ulcer, and they have a very erythematous base. It can be small, it can be large, it can be any size. And these ulcers are actually very, very painful. They can even involve, like as you can see, it can involve the tonsil as well as the pillars. So that is about aphthous ulcer. Next cause is malignancy of the tonsil. Now, malignancy of the tonsil, in these cases, you will be seeing the risk factors involved here are tobacco smoking, alcohol, exposure to human papillomavirus. The features that these patients will come to you with, that they will have a unilateral tonsillar enlargement. This is very important. Very rarely do we see a bilateral involvement here. So there will be a unilateral tonsillar enlargement. We'll see an ulcer with an indurated base. If you look at the image here, this is what typically a malignant ulcer looks like. This will bleed on touch, and the patient will also have hard palpable cervical lymph nodes and other histories like referred pain in ear, persistent sore throat, difficulty in swallowing. So these are the features that you will be seeing in a case of malignancy of tonsil. Very important feature here is that there's going to be unilateral involvement, an ulcer with an indurated base, which will bleed on touch, and hard palpable cervical nodes. Moving on to our next one, we have the two last malignancies, which is leukemia as well as agranulocytosis. So, in leukemia, what we'll see is this is basically a hematological malignancy. In children, 75% of leukemias are acute lymphoblastic, and 25% of them are acute myelogenous or chronic leukemia. Whereas in adults, we see only 20% of them are acute leukemias are the lymphocytic ones, and 80% are non-lymphocytic ones. So, in case of leukemia, if there's an ulcer formation happen, or if there's a membrane formation happening, this is mostly because of necrotic slough formation over the tonsil, and the patient will have other features like bleeding gums, anemia, hepatosplenomegaly. And when you look at the total count, it will be more than 1 lakh per millimeter cube. It may be even normal, or it can even be less than normal. But there will be a history of progressive anemia. And when you do a bone marrow examination of these cases, you will notice the presence of blast cells. So that is a little bit about leukemia. And last of all, our last differential diagnosis is agranulocytosis. Now, in agranulocytosis, what is it exactly? This is a very acute condition which involves a severe and dangerous leukopenia, which is reduction in the leukocytes. And this most commonly affects the neutrophils. Clinically, what you will see is ulcerative necrotic lesions not only on the tonsils but elsewhere in other parts of the oropharynx as well. And patient will be very severely ill. And in acute fulminant form, you'll see that the total count goes less than 2000 or even as low as 50. And the polymorph neutrophil may be reduced to 5% or less. And in case of chronic or the recurrent form, you'll see that the total count is less than 2000, and there will be less marked granulocytopenia. So these are all the differential diagnoses, the 10 differential diagnoses that we have on membrane over tonsil and how we are going to differentiate between them based on some investigations as well as some history points and clinical signs and symptoms. Now, when a patient like this presents to you with the things that you need to be doing is, first of all, we will take a very detailed history as well as perform a very detailed clinical examination of the patient. A lot of the features which I've already discussed. Next, we will perform a complete blood count in these patients. This complete blood count will help you in pointing out agranulocytosis or any other presence of leukemia or a presence of infection like infectious mononucleosis. Then we'll perform a peripheral smear for the patient. A peripheral smear can help you in exposing downy cells that we see in Epstein-Barr virus in case of infectious mononucleosis. Or we can even see atypical cells that we see in leukemia. Then we will also take a throat swab and culture. This will help with cases like diphtheria and Vincent angina. In diphtheria, you'll see Corynebacterium diphtheriae. In Vincent angina, you'll see the presence of fusiform bacilli and spirochetes, the Borrelia vincenti. We can see streptococcus in case of acute membranous tonsillitis. We can even diagnose candida from this. Next, we have Paul Bunnell test. Paul Bunnell test would be we'll be seeing high titers of heterophil antibody, which will be seen in case of infectious mononucleosis. Then when we can also do a bone marrow aspiration if indicated. This will help you in diagnosing leukemia. And lastly, for any suspected malignancy, we will be doing a malignancy. We'll be doing a biopsy. So these are all this is how we are going to approach a patient who comes to you with a case of different case of membrane over tonsil, and all of these history taking, clinical examination of the patient, and all the investigations, they will help you in coming to your diagnosis as to which case that is, and accordingly decide the treatment. I hope you have understood this, and if you have any doubt regarding this, please note them down in the comment section and I'll get back to you. Thank you.